shortly. Okay.
And we are, in fact, live. So apologies for the slight delay in getting the stream up and running, but welcome to everyone to the September meeting of Ealing's Health and Wellbeing Board. I'm Councillor Josh Blacker, Cabinet Member for Healthy Lives and Chair of this, and we've got various members.
Yeah, it's gone live. I'm just edit video and then customize.
Linda and Keith, if you might mute yourself. So we have quite a long agenda this evening, so I will kick off.
So see if you've got control. I'll be logging on to my other meeting, but not for in about half an hour. So I'll leave it running. Yeah.
So we will kick off with apologies for absence. We have a couple of apologies for lateness from councillors Raza and Nagpal, unless they've snuck in without me noticing. And we have apologies from councillors Wall and Steed. I think that's it for apologies. There are no urgent matters. Does anyone have any declarations of interest they need to make? No, fantastic. There are no matters to be considered in private. So we move to the minutes of the June meeting. Is everyone happy with those as a record of the June meeting? I'm seeing nods. Members have had several months to look at them, so hopefully any issues have been picked up already. So Daniel, did you have to have a brief, I know you didn't have a written report this month, but did you have a verbal update for us on the work of Healthwatch?
Yeah, apologies, Chair, for not having a physical presentation today, but can give a brief update. Again, apologies for the noise in the background as well. Hopefully it's not too distracting. So over the first quarter, we saw 1,243 patients. 99% of that was in person. Overall, we saw a 77% positive feedback about people's care and healthcare experience. Focusing on GPs, we saw 73% positive with staff and 74% positive on treatment and care. In regards to appointment availability, we unfortunately saw a drop with 54% positive. So quite a few people having difficulties getting appointments, as well as booking through the phone, receiving 50% negative. Just a lot of problems getting through to their GPs. Moving on to Ealing Hospital. We saw, to start with the positives, we saw 84% positive about the quality of care that people were receiving at Ealing Hospital, and a 91% positive around the treatment explanations. So it's great that doctors and nurses are just talking to their patients and kind of put people at ease. Where we're seeing the strongest negatives are around access to services, with a 47% negative, and wait times at the hospital being 36 positive and 35% negative, with the rest being neutral. Great cross-section of age, sex, and ethnicity represented in our survey. What I would like to bring attention to the board is around phone consultations. Now, we are not asking this directly, so these are patients bringing it up, and just a lot of negative feedback around phone consultations. The biggest thing that we're starting to see is the idea of patient choice, and basically a choice being taken away from people. So it's not so much whether or not phone consultations are bad, negative, or not as helpful. The issue is patients don't feel like they're having a choice and that they're being told what the way their appointment's going to go. This kind of draws us into the work around enhanced access. So we know that the national guidelines are encouraging a 50% split between in-person, face-to-face, and over the phone. So we greatly appreciate that both Northwest London and the council are pushing for a 60% split, so 60% in person with 40 over the phone in Ealing. And we think that that will go some ways to mitigating what we're seeing kind of bubble up as the negative. And that's everything from me. Thank you very much for your time.
Great, thank you. I think we can pick up some of the issues around appointments later when we come to that item. Were there any other questions for Daniel on Healthwatch's work? Simon.
So thanks, Daniel, for that feedback, and it's good to hear the positivity around the quality of care and the explanation around treatment. Certainly when we come on to my presentation, we'll sort of hear a bit more around the challenges that we've got even during the summer periods around the emergency pathway, and obviously we know we've got a significant backlog, and I'll say more about what we're doing about that later on as part of that. But I was interested in terms of a bit more around that sort of feedback on consultations and choice, really, in terms of was that specifically around the virtual ones, around the sort of telephone consultations or video consultations, or what was it both of those?
So it was definitely telephone consultations. We haven't gotten much feedback around video.
Right.
So yeah, it's been strictly telephone, and it's, like I said, it's coming up on their own behalf. Like I said, we have no direct question about it at this time.
Sure. Okay. All right. I'll probably say a bit more when I do my presentation a bit later on.
Great, thank you. Well, I think, Daniel, you're getting off lightly this evening with no further questions, but thank you. So we'll move on to some verbal updates, so further verbal updates. So first of all, from Anna Bryden, I think Mandy's here as well from the public health team on an update on their health and wellbeing strategy.
Thanks, Chair. So we're just going to do a short update. Can I just check you can hear me? My signal is not happy this evening. Good. Mandy and Ruxie are here from the public health team. There's been an awful lot of work happening the last couple of months. We had the Health and Wellbeing Board workshop back in, I think, June. And there's been an awful lot of work across the steering group with lots of people from different organisations. So a big thank you to everybody who's been involved. And the main focus has been both a thematic review, looking at what we've already heard from residents, and looking forward at how we can build up a really good engagement programme to develop the strategy. So if you're happy, Chair, I'll hand over to Mandy. I think Kerry is going to very kindly share our slides in between all our IT issues, and I'll hand over to Mandy. Thanks.
Thank you. So, Kerry, is that okay to help us with the slides? Thank you. So if we could just move to the next slide, thank you. So there's a lot more detail here than we're conscious. It's a packed agenda today, so this is very much just an update and a snapshot, really, in terms of progress. As Anna had mentioned, there's been a lot of activity, and particularly from the cross-partner steering group, which has representation from organisations within the board and with the CVS partners as well. And we've got Daniel and other colleagues as part of that. So there's been a lot of activity over the past few months. The key focus has been, as was agreed and the steer from the board previously, is around this time looking at what we know in terms of the impact that the pandemic shone a light, really, in terms of inequalities, and particularly in terms of compounded and multiple inequalities for people within the borough. And this time looking at the 5-year health and wellbeing strategy as a bit of a map, that opportunity to have those common set of goals working together across healthcare and the community and voluntary sector as well. And very much the focus this time on looking at structural, strategic and system level actions. So where we can, looking at addressing some of the underlying causes of the causes. As part of this, I know we shared previously, we've got some work that's progressed with the steering group, have developed a pack and resources and are undergoing discussions and work with community partners, because at the heart of this work is going to be community-led engagement. So from community leaders, focus groups and guided discussions around, based on the what matters to you approach very much. So what are the day-to-day challenges, barriers, the factors that people are living with for them, their families and their neighbourhoods that will impact on their health and well-being? So looking at that in terms of barriers and challenges, but also in terms of the assets, because recognising the strengths and the resilience there is within the community, within the borough. So very much that's going to be at the heart of what we then bring to the Health and Wellbeing boards at a later date. And also there's going to be a follow-up workshop with board members that we're looking at dates currently in November. So very much bringing together some of those insights. Just a quick headline, so we won't go into all the detail here, but as Anna mentioned, we know there's been a significant, considerable number of consultations in the borough, and we've had feedback from residents and community partners around people feeling a bit consultation fatigue, potentially, you know, wanting to know, are they being heard? So as part of this, we've pulled together all of the recent consultation feedback and insights, and have conducted with partners a thematic analysis of this. And that's helping to drive some of the intelligence that we'll be bringing back to the board at a later stage. So just a couple of insights. You'll be familiar with this, I'm sure, but there's just some key factors really, thinking from a structural perspective and systems perspective. So thinking about the 10% rise in work poverty for families in the borough. And that's before the recent fuel cap changes and the autumn changes and what's happening with that. So that there's some ongoing factors there. We're working with Ealing Food Bank, and we're going to be having some focus group and sort of drop-in sessions as part of the engagement at some of the food bank sites. I'm not sure if you're aware, but it was quite surprising to hear really, but Ealing is the 4th busiest food bank in the country. So there's significant level of need, and food bank partners have been saying that actually there's food bank usage and need from within every single ward in the borough. So and this is pre the kind of escalation that's happening currently around the cost of living crisis as well. So we know that there's significant needs there, but there's also, you know, there's great level of insight with partners like food bank partners and others that we'll be working with. So as mentioned, there's going to be a series of community conversations. Some of those have already started. They'll be ongoing over the next couple of months. And in terms of the collaborative work with NHS partners and colleagues as well, that's opening up opportunities as well. So we're going to be having some also utilising facilities within West Ealing Library, so the information screens and things like that, as well as GP practices as well. So just to give you a snapshot really of that. And I'm going to hand over to Roxy. So next slide, please. Oh, I think we skipped. That's it. Yeah, thank you.
Thank you. Thanks, Carrie and Mandy. So just to continue very briefly on what Mandy has said, in terms of setting the priorities for the strategy, those haven't been set yet. But following the workshop we had in June and extensive discussions within the steering group, as Anna and Mandy said, we have identified some potential approaches for the health and well-being strategy to be delivered, and also ways of working, and not to go through the whole list, but that's just to touch on a couple of very important ones that we think would be crucial for supporting the delivery of the strategy. First of all, it would be to identify health and well-being strategy champions amongst the health and well-being board senior leads who will widely promote and embed the strategy and its aims. And secondly, it would be how us as anchor institution can show our ongoing commitment to the aims of the strategy by building into the existing partners that and partnerships that we already have, but also keeping a continuous link with the communities and supporting those communities and organizations in the community that do have a lot of positive impact in their areas in terms of the health and well-being of the populations. So if you could move on to the next slide, this is just a small reminder for everyone on the timeline of the strategy. So we're hoping to bring a draft at the next Health and Wellbeing Board, and we're also working on a workshop on the second workshop at the beginning of November, just figuring out the dates at the moment, and those will be sent out as soon as we have confirmation. That's it from us. I don't know if you have any questions. Thank you.
Right, thank you. I'm just gonna oh, brilliant. Now I can see everyone. Any questions for Anna, Mandy, and Roxy then? No, excellent. Thank you very much, the three of you then. Slightly Kerry, where have you? Oh, you're there, Kerry. Sorry, people keep shifting around on my screen and I'm still not used to it. Kerry, Health and Care Act implementation planning update for us.
Thank you, Chair. This is the information that's been shared with regards to the impacts of Health and Care Act changes. It's an information piece. A significant amount of work is going on for the shifts within local government, but also within health, including CQC inspection programme being reinstated for adult social care as of April 23, but also the significant changes to the charging arrangements and fair cost of care piece of work. This is for information, Chair, but I think it's really important that we recognise as a system that the fair cost of care and the charging arrangements are going to significantly change the customer base for local authorities as self-funders come into the workflow for adult social care and for the council, but also that the fair cost of care arrangements are likely to significantly increase the cost of services that we procure, and that won't just be for local government, that will also impact on the NHS. What I'd propose that we do, Councillor Blacker, is that bring further updates to this meeting as the programme progresses. We're expecting to see some significant outputs in the next couple of months in terms of the fair cost of care exercise, but this is almost setting the scene, and then propose to bring further updates to the Health and Wellbeing Board as we progress.
Thanks, Kerry. I know you and the team are doing a huge amount of work on this. So these slides are dense, but don't even represent the tip of the iceberg. So thanks for that. Are there any questions for Kerry on this update then, specifically? Kerry, you have a question for yourself.
Thank you. It did seem a bit strange, and I saw Simon's hand go up just after my own. I think what we also will need to include colleagues from North West London, ICS, with regard to this, where the continuing healthcare funding sits, because I think it's going to be a sub-regional issue, and we'll be feeding the information upwards to the sub-regional NHS leads.
Thanks. Simon, you did want to ask something.
Yeah, I was just going to ask Kerry from his perspective, to what extent do you think it'll manifest itself in additional costs to the NHS, and why, I suppose? Is it around delayed discharges, or is it about pure cost of placements and the value of the cost?
I think it's a really good question, Simon. I don't think there'll be a direct impact on discharge pathways, other than that the price of care packages is likely to increase as the fair cost of care programme comes through. We're still waiting to confirm to what level that will increase. But I think if you think of continuing healthcare funding pathways and social care funding pathways, they're both likely to be impacted. Potentially there will be a knock-on the discharge pathway, but that's something we will try and minimise.
Okay, so it's around the placement budgets, you see it effectively?
Effectively, yeah.
Okay.
Great. Neha.
Thank you. And Kerry, I know you will consider this, but remember there's the local complex care team as well. So as well as having a conversation with the North West London team, it's critical that the local teams are as involved in those conversations.
Now I'm muted.
Josh.
I'll get there eventually. Thanks, Kerry. Great. So I think, yes, let's have further updates as we go through. I know you're giving updates to other bodies, Cabinet and SLT as well, but helpful to have it here just for partners' awareness. So thank you. Now if I can get back to the top of the agenda, we move on to the do we want to do Health and Wellbeing Board work programme now, Anna, or do we want to come back to that at the end, I think?
Yeah, potentially at the end. Either's
Okay.
fine. Thanks, Josh.
Sorry, and I think that we've missed one that we've moved around on the agenda. So I think that takes us then to Simon on Ealing Enhanced Access. Oh no, not Simon. Chris. Simon.
Neha and Peter, I think.
I'm just going through all the NHS partners just to work out who's doing it. I should have known that. Apologies.
DJ will do the access and then I'll take over.
Yeah. So can someone share the slides, or I'm happy to just talk through them. So really, this is coming to the Health and Wellbeing Board to describe what configuration arrangements are going to happen in terms of extended access across Northwest London and particularly for Ealing. So a little bit of background first of all. So we've had two types of extended access in primary care for the last five years or so. So we've had the individual PCN delivery of access, which primarily is individual practices providing extended access with early appointments before 8 o'clock in the morning and evening appointments, and some practices have been providing weekend appointments, as well as our 3 extended access hubs, which are Sunrise, Florence Road and Elmbank. And they've been providing evening appointments between 6:30 and 8, Monday to Friday, and 8 to 8 on Saturdays, Sundays and bank holidays. And that has equated for Ealing to 423 hours per week. NHS England developed a new access specification nationally for PCN delivery, which goes live from the 1st of October this year. So the second slide describes what is going to happen from October. And in essence, what NHS England have specified is that PCNs, primary care networks, will be delivering access between 6:30 and 8 Monday to Friday and 9 to 5 on Saturday only. And the requirement was for 60 minutes per 1,000 patients per week. So in terms of totality of appointments, this in fact equates to just above 435 hours, which is more than what we currently provide in Ealing. However, it does not specify or is not mandated that PCNs would be providing access on Sundays and bank holidays. And the remit of the extended access is not only about reactive care, but it's also about proactive care out of normal GP core contract hours, and hence it's a multidisciplinary approach in terms of who's going to be delivering that access. Not only GPs and nurses, but also includes healthcare assistants, clinical pharmacists, paramedics, and other allied health professionals who work in primary care. And it's a blend of access modalities, including face-to-face and remote consultation. So the next slide just describes what our PCNs, our 8 PCNs across Ealing have developed in terms of their PCN plans. So 4 of the PCNs, as highlighted here, are going to provide what we describe as a single hub model. So they will have one hub to deliver this for their PCN practice population. And what it describes here is how they're going to deliver that in terms of the specifications according to the national contract. And obviously the hours are different because their population size is different. And then 4 of the hubs or PCNs are providing a multiple hub practice-based hybrid model of delivery. And that entails a rotational basis of which site would be the hub at an evening or a weekend, and individual practices within that PCN also providing that extended access support to the PCN. And then this is again described for each of these 4 PCNs. The next slide describes what process we went through. So we went through an assurance process in terms of locally the borough team reviewed and scrutinised the PCN plans, and we had an iterative process with the PCNs in terms of key lines of inquiry and clarification questions, which the PCNs then resubmitted, and the plans went to centrally to Northwest London for endorsement and approval. And all of the 8 plans for Ealing PCNs have all been approved for delivery starting on the 1st of October. The next slide just describes some of the risks and issues. So clearly the first risk that everyone would have noted is that the national contract is not aligned to what we have been providing, not only in Ealing and North West London, but all actually in fact across London. So over the last 5 years, London have been somewhat unique compared to the rest of the country in the fact that they've had access hubs, evenings, Saturdays and Sundays and bank holidays for the last 5 years. So NHS England London region are currently considering what would be the position that they take in terms of what they need to do with respect to that deficit in provision over the 7-day period. And at the moment, they're considering their options in terms of what we can do or what can a system do to support the rest of the system. So really, primarily, it's about supporting the urgent care pathways on Saturday, on parts of Saturday, but mainly Sunday and bank holiday, with respect to urgent care. So supporting 111 redirection, our UTCs and our A&Es in terms of providing that extra support, and particularly in view of the pressure that the system has been under, but also to take into consideration the winter pressure, which is going to come our way. So at this point in time, we haven't got the detail as to yet in terms of what the plans and proposals may potentially be for Sunday and bank holiday, and that is currently being worked through in terms of how we manage that shortfall. The other risks are around sort of operational issues. Again, there are some logistics around PCN delivery, particularly in terms of the interoperability of the System 1 unit, particularly for planned care, where you have continuity of care to manage ongoing investigations, ongoing referrals, which are being managed outside the normal practice environment where that patient is registered, how we manage that operationally. And there are logistics around the pathways and processes, but also in terms of clinical responsibility as well. And then in terms of some of the other issues, each of the PCNs was asked to engage with their PCN population in terms of reaching out to them with respect to what the population would want in terms of access. And each of the PCNs came back, and predominantly the feedback was that the population wanted evening and Saturday appointments, and there was little interest in Sunday appointments. I guess one needs to interpret that with caution, because clearly that may well be appropriate for proactive and planned care, but obviously if someone's ill on a Sunday, where it's not predicted to happen, then clearly they would want to have access in their locality, preferably, rather than having to go to an urgent care centre or A&E. So one needs to interpret the feedback with a pinch of salt in terms of how that feedback was received. And then finally, the last slide just goes through the approval and the governance process which has taken place. And as I said, these plans are ready to go live in terms of the new contract, which will be from the 1st of October this year. However, we do have only several weeks to really work through as a system and as a borough working with NHS England in terms of what we do on a Sunday and bank holiday. So, time is of the essence in terms of once we get the clarity from NHS England London region of how that is going to be approached for Northwest London and in fact for the rest of London. Any questions for me on the extended access?
Simon.
So it's not so much a question, but I certainly share the concerns around the risks and moving from the current arrangements that are in place. As we'll hear later, we continue to see significant demand on the emergency pathway throughout the summer period. We're going into a winter period. We don't know the impact of COVID, although hopefully it won't be a major issue in terms of COVID, but we know flu is coming our way, and certainly Australia. If Australia, which we normally follow as anything to go by, it's going to be a significant year challenges for flu this year. So any reduction in the availability of GP appointments is a concern to us, and also it's not just a pure reduction; it's about the confusion maybe for the public as well. So I think it's really important in terms of the communication around being clear what still is available in primary care, half 6 to 8 o'clock, and on Saturdays. I think it's absolutely mission critical that there is a good communication plan around that. But as you've alluded to, we always know we come in on a Tuesday after a bank holiday weekend, having been seeing significant pressure on all of our acute sites. And again, I think if we're faced with Sunday and bank holidays without appropriate access to primary care intervention, then that's going to present significant challenges going forward. So I understand where we are. So I haven't so much got questions about it, but share the concerns, and I think really the communication is mission critical to be clear what will still be available in primary care and how to access it for patients.
Yeah, absolutely, Simon. That is going to be mission critical. Yeah.
Anyone else for VJ? Otherwise, I shall kind of use the chair just to pick up the thread earlier about the split between telephone, face-to-face, and online. Just how fixed are those, and how will that be measured and kind of amended? Because looking at it, 25% online, Acton, you think, okay, Acton's the youngest part of the borough, might work better, but how are the PCNs or the borough kind of team going to monitor that and say, actually, that's not working and we need to adjust?
Yeah, so at the moment, in terms of what the PCN plans are described, these are sort of indicative mixtures and blends of access modalities. It really will depend on what once the access hubs go live in terms of what is right for the population and how that. So there will be a level of understanding, learning, and then flexibility in terms of managing that. In terms of monitoring that, yes, we have got the means to monitor it, because all the hubs will be on the System 1 platform. So and we can differentiate between the various appointment slot types to determine what type of appointment it is. So we will be able to, and we have been doing that in any case in our hubs up until now. So we will be able to manage that and monitor that, and then have those reviews with the hubs and the PCNs in terms of what they may need to do going forward in terms of flexing that differential proportion.
Okay, thanks, VJ. Any other questions, comments on the plan for VJ? No, thank you, VJ. So I think we then switch to Neha. I'm going to make an educated guess on this one for a vaccination program update.
Thank you. I'm just going to share my screen because I've got some slightly updated slides. As you can imagine, this whole program is very fast moving, and plus I've got an update on polio vaccinations as well. So just bear with me while I share my screen. So you should now be able to see the slides. Great, fantastic. And apologies, I'm looking away from the camera. It's on my other screen. So where there have been changes, the changes are in red. So you can see very clearly what has been changed since the version that was published. So just to update, just to remind you all, we have the COVID vaccination program and the flu vaccination program coming up. It's started now. In fact, our care home program across Northwest London started on Monday, and the wider program for COVID vaccination starts on the coming Monday. In Ealing, we have more pharmacy sites than anywhere else in Northwest London, but we have 15 pharmacy sites now delivering the vaccination, but we do still have some gaps in geography, but we still have the highest number of vaccination sites. And our community pharmacy sites will be the main point where vaccinations will be delivered. We also have CP House in Ealing, but that will be coming to an end from a day-to-day vaccination program perspective over the coming months. But the roving team that are based there will be going out to various sites across the whole of Northwest London, including sites in Ealing, to deliver the vaccination program. In addition, we have one primary care network, so PCN, that we were just talking about in Northolt, that is just currently going through the final bits of assurance to be able to provide the vaccinations to their own patients. And we're also working with the Argyle Care Home Services hosted under ECP, run by the ECP program, service under West London, and Mattock Lane Pharmacy, along with the roving team from CP House, to deliver all the vaccinations for care homes patients, which is, we've got 1,000, nearly 1,300 people in care home beds across the borough in Ealing. Plus all of our housebound patients, unless they're from the Northolt PCN, they will be offered the vaccine through CP House roving team. So I'm just going to go through a couple of other slides. So this slide is in your pack, so I'm not going to go through it in detail, but you will all know about the JCVI advice to start the autumn COVID vaccination program with all adults aged 50 years and over, plus these other cohorts as well, including our frontline teams and certain population groups between 5 and 49 who are clinical risk or housebound contacts or carers. As I've already discussed, CP House will provide quite a lot of capacity, but they're providing capacity. They're a hub for the whole of Northwest London, not just Ealing. And you will see in some of the planning figures that we have, the planning comes under Ealing, but not all of it is delivered for Ealing, although some of it is. These are all of our pharmacy sites in Ealing that will be delivering the vaccination. And as you can see from our planning and our modelling, actually we have an eligible population of 178,000 plus our workforce, but we have an available capacity way over that eligibility. So we do believe that we've got more than enough capacity within the borough. And as I was describing before, we do have a couple of areas where there is a bit of a gap in terms of a pharmacy being assured to deliver the vaccination, but there's not very far that patients would have to travel to get a vaccine. And just because a pharmacy isn't within Ealing, it doesn't mean that they can't go to another site just across the border. I know, for example, there is a vaccination site just here. So the patients in the Northolt area may actually choose to travel through there, the booking system will be exactly the same, the national booking system. So it won't affect in terms of how you book. The patients can go to anywhere that's closest to them. Just like our residents outside of the Ealing Borough can access any of the sites within Ealing as well. I'm not going to go through anything more. I've already spoken about the care homes. One of the pieces of work that we have to make sure that we stay on top of is the outreach work and making every contact count and reaching out to cohorts to keep on encouraging take up of the vaccination over the program of over the coming months. And we've continued that right the way through, and that still continues. And we do specific work around. So yesterday we had an event in the Dominion Centre, for example, where we were promoting vaccinations to any of our population that were coming in. We will continue to work with some of our homeless providers, service providers like St Mungo's and some of the other areas, asylum seekers, any migrants, refugees, the Ukrainian population, and any other populations that we identify. That will continue to be a rolling programme. If you don't mind, I will continue into the polio vaccinations and then take the questions at the end. Apologies, I'm not sure that these slides have made them into the pack in public, but I will make sure I send them through to Keith and get them uploaded for the public with the minutes. But you will all have heard in August, early August, UXA had declared a national enhanced polio incident response, and the JCVI advised that we should be offering a polio booster vaccine to all 1 to 9-year-olds in London. The programme started in the east of London and certain other boroughs, including Brent, and then we went live literally just about a week later in terms of our planning. So this is to update you all on where we've got to. The ask has been for us to put systems and processes in place to deliver that polio vaccine or offer the vaccine to parents of all 1 to 9-year-olds by the 26th of September. So as you can imagine, there's been a lot of work to try and get that in place. And what we've managed to do is establish a program where the 1 to 4-year-olds, they can't be vaccinated in any other sites. They have to be vaccinated by the GP practices at this stage. However, there are other routes being considered nationally. So 2/3 of our GP practices across the borough have agreed and are starting to offer the booster vaccination to their 1 to 4-year-olds. And the 5 to 9-year-olds will be offered the vaccination through a couple of routes. So CP House went live on Thursday, offering the vaccination for 5 to 9-year-olds. And this week, we're just finalising all of the details, but 2 pharmacy sites will also be delivering the vaccination, and that's Mattock Lane Pharmacy and Gill Pharmacy. And they've just gone through the assurance process, and we're just getting the supply and the IT system sorted so that they can deliver the vaccination to the 5 to 9-year-olds. But the program is quite specific in that it's only registered healthcare professionals that can deliver the vaccination. So it's not as easy to deliver as the COVID vaccination has been. And you will remember from very, very early days of the COVID vaccination, this was some of the issues that we had initially. So there was letters have been sent out. There's been a lot of media work, and our normal national call and recall services have been taking effect and putting letters and communications out. And our GPs have also been sent the information to be able to start to call our children in and make sure that they've got the supply of the vaccine in the pharmacy. Where I said 2/3 or 3/4 of our pharmacy, our GP practices are offering the polio vaccine to 1 to 4-year-olds. Where there is a gap, where a practice isn't able to offer that due to various reasons, we are working with the national team to ensure that but the CP house and the 2 pharmacy sites are able to fill that gap very shortly. So that hopefully, as I said, this is a very, very fast moving program along with all of the other vaccination programs, hence some of my updates, but this is the position as we are today, and it will continue to change. And we've got a number of key bits of information ready to share out with our population. And nationally, there is, for example, a flow chart, an algorithm as to which vaccinations are offered to the child, depending on where they are on their program, what their age is, whether they've had any vaccinations before or not. So we're all working to those national programs. And these are the 3 vaccinations offered to, depending on where that child is on the pathway. So I'm just going to stop sharing, but happy to take any questions on either of those.
Thanks, Neha. And having another vaccination program thrown at you after the last couple of years isn't particularly fair, but thanks for stepping up to the challenges as always. Kerry, I think they're in order that way, so I'll go Kerry and then Vijay and Pam.
Thank you. It's not a question as such, but Neha, as previously, if you need any support at all with accessing the care homes, because we've got the contacts within local government, we'll provide all the support we can to you.
Vijay.
Yeah, it's not a question. It's just to add for clarification in terms of the COVID vaccination in terms of the over 50. So the process for the booking of the COVID vaccination is through the national booking system, but that is going to be phased in. So it's gone live now as of today. But so as of today, anyone over the age of 75 plus frontline health and social care work, as well as the extremely immunosuppressed, will be able to book their COVID vaccination. And then the plan is next week they will then open it up to over 65s and then the over 50s. So it's going to be phased in over the next 2 to 3 weeks. So not everyone can suddenly jump on to the national booking system as of today when they're over at the age of 50.
Thanks, Vijay. Councillor Nagpal.
Thanks, Chair. Neha, that was really helpful on the polio booster programme for children up to the age of 9. I just wondered what the take-up has been like to date, and how quickly do we think we're going to get children vaccinated? And also, if we've considered, or if we are looking, have looked at or will be looking at vaccinating children in school. I was just thinking back to when I had my booster, and I'm sure it was in school, and maybe that's a way of getting children vaccinated quite quickly.
So I will defer to Dr. Vijay Taylor about the take-up rate from his practice experience so far. I haven't got any of the data at the moment, to be honest, but the appointments at CP House have immediately started to be used. I think on the first day there were 46 children that were vaccinated just on the first day. So there is definitely take-up, but obviously there are children who haven't had any vaccinations. So there will be a group of children whose parents are not willing to give that vaccination, and there's a lot of work to do to help unpick some of that and provide the offer at least. But in terms of the school vaccination program, we've been talking to the school team. We have literally weekly and every 2 times a week meetings, which include health visitors and some of our school vaccination team. They haven't got the capacity to do it because obviously they're trying to ensure that as the schools open, they've got their vaccination programs already lined up for the year. So they haven't got the capacity to do it. And for 1 to 4-year-olds, they have to be done with a GP practice at this point anyway. And there is a lot of consenting and everything that has to happen with the school teams as well. I don't know if Vijay wants to add anything to that.
Yeah, it's it is too early to say what the uptake will be, in terms of the children coming forward. I think what we're finding so far, the early findings are that it's primarily the children who are up to date with the immunization program, where the parents are proactive to book them for the polio booster. But we have a large cohort of children who are either, we have no history of their vaccination record, and that may well be because they have come from abroad, or that's a choice that parents have made from the outset, or there are children who have a partial scheduled program, and those ones, as you know, primary care have been working throughout the year for many years now to try and encourage those parents to bring their children in. So, we honestly don't know what the uptake is going to be at this stage. Bear in mind lots of the confounding issues, but certainly we will have a better understanding over the coming weeks.
Thanks, Vijay. Judith.
Yeah, just coming back to Acton as an area where we know that take-up was less strong previously, and there's a slight gap in provision in the Acton area for the vaccination programme. Is there anything we can do now to support that and make sure that we get as much take-up as we can?
Yeah, there is always more that we can do to try and reach out to the population group, and I continue to ask if there are any pharmacy sites that could that would be willing to put themselves forward. And it feels like we always get one or two coming forward, and then they just don't make it past the mark for various reasons, and we'll continue to do that. But I think the pop-up and the roving teams going into, for example, St Mary's Church or some other routes, like we've done in the past, are really essential. But I think this is where I would ask everybody that works in the Acton area to help us out as much as they can to get that message out there, or put us in touch with groups that we could go and talk to and offer the vaccine, or just answer questions and just support, and always open to any of those conversations for all of the vaccination programs, not just COVID.
Thanks, Neha.
Great. Anything else on the vaccination programs for Neha and Vijay? No. Well, thank you. And as ever, I think has been mentioned, any support we can offer is on the table for you. It's our population that we want to help you protect as much as you do. So anything we can do, just let us know. So I think we move on to Simon and Joe for the London North West Trust update.
Thank you. Yeah. So Joe, I hope will share the presentation, but hopefully you've all a chance to look at it in advance. It's in three parts really. Three elements. One in terms of recovery, which I'll split into elective and non-elective, winter planning, and our trust strategy development. So if we go to the first slide, Joe. So in terms of on the elective recovery side, the national expectation is for trusts on the elective side to do 107% of what they were doing pre-COVID. So recognizing as a result of COVID, backlogs built up as part of NHS planning guides, the expectation is trusts will deliver 107% elective. That's your day cases, your inpatients, your operational procedures, your endoscopies included as part of that. So 107%. For August of this year, we delivered 102% in London Northwest. So ignore, I'll come on to those. Those are sort of waiting time type figures on the screen. So in terms of the headline messages, in terms of the overall level of activity, we did 102% versus the target 107%, which we're pretty pleased with in the context of, this summer is the first summer that some of our senior clinicians have had a chance to take a full fortnight's holiday and that kind of stuff. So we've had lots lots of holiday over this period, but we've still been able to do more this August than we did in pre-COVID levels. The expectations on first outpatient appointments. So again, recognizing the backlog of referrals, the expectation for government is we focus on new referrals. Those people have been waiting a long time and try and see as many of those as possible. So the target is 120%. In August, we did 105%. So again, we're on the right trajectory. There's more to do. We expect to back up the second half of the year from October onwards, expect to get towards closer to the 120%. And for follow-ups, the expectation is that there is the potential to do less follow-ups of the patients and use patient-initiated follow-up and longer periods between some of the follow-ups. And the target from government is that we reduce that down to 75%. And for August, we'd reduce it down to 91%. So focusing on more first, reducing the follow-ups, we're on the right sort of pathway. And then in terms of in endoscopy, we delivered 102% of the target against the 107%. So making good progress in terms of our activity for August. In terms of waiting times, then in terms of responsiveness, you can see from there in terms of referrals to treatment pathways, those waiting less than 18 weeks, we're seeing just under 66% in less than 18 weeks. That puts us 10th in London. Waits for diagnostics, we're doing extremely well with sort of 4th in London. In terms of cancer, in terms of the first treatment, we're 8th in London, and waits for emergency care, we're 4th in London. And that's despite the challenges that we have in terms of Northwick Park being the busiest in London on any one day, receiving the most LAS ambulance attenders on any one day. And clearly what we're doing is sharing the burden between Northwick and Ealing, where it's appropriate for those patients on the border to make sure that they come to Ealing, which helps improve the waiting list, takes the pressure of Northwick Park, but it also helps if there is an Ealing residents and they are admitted, it also helps on the discharge planning process as well. So our focus is very much on cancer and on the long waiters. We had no 104-week waiters at the end of July, which this data relates to. We did have one in August, but we are focusing on those and managing those on an individual basis. The one that did breach was as a result of that patient being abroad, but has been scheduled for their procedure during September. And we are returning cancer 62-day waits to sort of pre-COVID levels. We do recognize those. So part of our challenge is the rising demand in terms of referrals on the 2-week wait pathways from GPs. So we are looking at what we can do with them in terms of prioritizing those and making sure that they are all appropriate referrals. And we obviously are scaling up our diagnostics capacity in terms of making sure that we can respond to those referrals appropriately. And our theatre utilisation, we've done a lot since last April, really. So in terms of making sure that we've got much better processes for booking our patients into theatres, making sure that we're doing the pre-op assessment in a timely way, and we've seen significant reductions in patients not ending up not being fit for a procedure in the week of the appointment, the procedure, or on the day. So we've done a lot to try and make sure that having booked a patient, we've prepped them and supported them to be able to go ahead with their procedure. So in terms of next steps, I think I might have probably covered this as I've gone through on the last. So working with primary care partners to address and understand the increased referrals and making sure that those are appropriate. I mentioned about the diagnostics, and we're focusing on the backlogs, as I said. So in terms of capacity, staff is a challenge for us. We've lost staff through the COVID. We've recruited others, but staffing is still a challenge. So we do use waiting list initiatives. So that links to my comment earlier, really, in terms of needed to give staff a break, because those same staff who rose to the challenge during COVID are the same staff we're asking to do additional waiting list initiatives and go the extra mile. So it is important that we support and think about their well-being as well as sort of taking advantage of their goodwill to try and ensure that they will do additional shifts and provide that additional capacity. We are planning ahead for winter. We have recruited and put in place additional equipment. Perhaps Joe will say something a bit more in terms of equipment on the Ealing site. So we're delighted that the new cath lab is going to open later this month in September, and that will also help the diagnostics and the capacity side of things. And then in terms of 18 weeks referrals, again, we're doing quite a lot in terms of making sure that we're not losing patients on the waiting list, by making sure that we're doing much more around text messaging, phone reminders, etc. And also done quite a bit, I think, as a result of patient feedback to improve the type of messaging and the timeliness of that and reminders in terms of that. I've talked about capacity. And the other thing, I think we've looked at the scheduling, we've looked at how we use our theatres, and whereas before we might have been putting 4 on the list, we're putting 5 on a list, etc. We're trying to make sure that if we got a long case, but it won't take up the full theatre session, and we can get a less complex case at the end of the session and that kind of thing. So trying to make sure we're making maximum use of the capacity that we've got. So I'll stop on the elective side. Joe, did you want to do the non-elective, and then you can pick up Ealing as part of that?
Sure, thank you. So in terms of non-elective, the pressures continue. We at Northwick receive still the most ambulances of any trust, London trust or A&E department. So over the last 4 or 5 months, we've been working with LAS around some specific agreements to move postcodes that have traditionally gone to Northwick Park to Ealing. We started in early February with UB5 and UB6 postcodes, and we have more recently been looking to support HA0 and HA9. These have actually, so UB5 and UB6, we have seen that pretty much consolidated, and that activity is now pretty much moving across into Ealing Hospital. But we are still getting some sporadic kind of, Northwick is still getting surges, particularly out of hours. So we're working with LAS on this. I think the message is that we are seeing winter level attendances and activity through the summer. So last night, to give you an example, we'd normally be looking at 100 or under 100 at this time of year. We saw 131 in A&E last night at Ealing and 117 the night before. So we're getting a lot of activity. Admissions are around 40 at Ealing and 80 at Northwick Park, with bed occupancy high. And we are still seeing high volume of mental health presentations in A&B, and then challenges with placements across more at Northwick, I'd say, but we're still having some challenges. So demands on the teams and clinical and support staff is significant. I think the work that we've done to date, and we're at the moment piloting some schemes in A&E to look at how we can improve triage and the handover process and fast streaming patients through A&E. There are a range of measures going in play. We've also, in terms of some of the upgrades Simon was talking about, we've just upgraded our MRI, and that refurbishment's completed. And on stream at Ealing, we were using one of the scanners at the back of the hospital for a period while that work was in training. It took around 3 to 4 months. And as Simon says, we've got the cath lab coming on stream. And we're putting in more. We've obviously got the upgrades we've done to ITU, which is running at a capacity of 12, and we've got additional monitors and things coming into play as well to support some of the activity and the workload that we're seeing. So I think if there's anything else, Simon, you'd want to reflect around non-elective.
I don't think so. We'll respond to questions in a sec, but if you go into winter planning, so all of that feeds into the importance of getting our winter planning right, and it also feeds into my comments earlier around, any reduction in access to GP appointments that means more come to the hospital would be challenging. So we've got to collectively get our sort of winter planning right. So, sorry, Joe, I didn't realise you still had a slide
no, that's fine.
on elective recovery, because the next bit is around winter planning. But if you flick through this and then move on to winter planning. So
we do have our regular sort of meetings, site meetings, which the Urgent Treatment Centre is part of, and we work closely with them around some of their staffing challenges. We are maximising the SDEC, so the same day emergency care facilities, and that's been growing, and we're looking at adding further services into that. And as Simon said, work is underway, and I'll come on to that around winter planning. Around the redirection pathway, so trying to get patients to community services, that's a piece of work we've been progressing at Northwick. We'd like to try and do it at Ealing, but I think it's certainly in light of some of the discussions earlier about the out-of-hours work, maybe it's not so easy to achieve. Working obviously with mental health and social care partners, and daily repatriation, so making sure that we get repats out for stroke services, but we also receive promptly repatriations from other hospitals, so they will take our patients when we need them. And work around our clinical decision units and creating chair capacity so that we can keep the flow going through A&E. These are areas that we kind of are hot sort of subjects that we're monitoring and working on daily. Coming on to winter planning. So the key principles for winter planning, and some of these are ones we've had before, but continue. So having the right bed occupancy levels is really important. Too high, and we don't have the flow and can't move patients through. Too low, clearly, and that's not an issue that we have at the moment. But keeping our bed occupancies around the 95% level is what we're working towards. Helping our emergency team, so we have fewer patients sitting in A&E at the start of the day, so making sure that we're moving people through the system, supporting our activity levels, particularly around our elective bed base. So the feature for this winter is that we have to continue to deliver the recovery work that we've done in surgery. So in previous winters, we might have actually taken out more surgical beds and paused activity in order to support work that we're doing. This year, we've got to maintain the position all the way through. So ensuring we've got that bed base protected, and we're working that through, and not encroaching on that with our emergency activity is key. Getting the right, the patient into the right bed. So making sure that we're not doing multiple moves to get to the right specialty. They're assessed promptly in A&E, and we can flow through straight into the right specialty bed base. And improvements in terms of quality of care, safety, and how we're using our resources, and patient satisfaction and outcomes. And then maximising our recruitment and maintaining the grip on use of agency. Clearly, we will need more staff over the winter, but recognising as well that it's not a limitless pot. So being very clear and focused about where we're going to need extra work, capacity and support. Some of the assumptions that we're making, so where possible, we're going to open existing capacity on wards rather than opening new capacity. So we have flexed down some capacity over the summer, and we're aiming to open that over the winter. So across Ealing, we'll be opening around 40 beds. And that means that we have existing sort of teams and specialists on those wards, and then we'll boost the support of those areas in order to open the capacity rather than opening new wards. Infection prevention, we heard earlier about the concerns around Australia, so ensuring that we get IPC and continue to monitor that and support around the flu and our COVID vaccination program. But we're working on closures, bed closures around our infection control of around 5%. Targeting as well our community-based schemes in terms of demand for beds with the ICE system of referral for inpatient rehab and across the hospitals for support, whether it's critical care or specialty referrals to tertiary centres. Continuing implementation of our discharge action plan. So we've got Sasha Harmsworth-Blythe, a new head of discharge, and has got a very comprehensive plan going from board rounds, ward rounds, and electronic data to help us give timely information to wards and moving people through right the way through to then planning from our P1s to P3s with partners in terms of getting people moved out. We've also had a new program started. I think we've mentioned and discussed it before, but the Homeless Pathway, a scheme that's supporting discharge of homeless patients as part of our more complex end. So continued work with that and growth of those areas. Support from partners clearly is critical to get people out. So timely delivery of our packages of care and placements. And lastly, the coordination around the community beds across North West London to prevent our inpatient and hospital delays. Risks, we haven't seen a reduction in activity. So we're looking at expecting a surge, but maybe we've seen a surge because of the pent-up demand post-COVID, and there won't be so much. I live maybe in false hope. I think we are expecting there to be a surge in demand. Patients who choose to come to acute and to UCC rather than going into community and to primary care, increased pressure around mental health services. And I know that's been a feature for everyone, but continued growth in that will be a risk. Any further impact around the pandemic, but particularly because of the vacancies that we have seen in terms of the recruitment of our staff and getting them in for the winter. And lastly, as I said earlier, we have to continue to balance the requirements of delivering our elective recovery versus the non-elective demand coming through A&E. So I'll hand over, Simon, to you for the last bit.
Well, should we pause at that point? Because I think our way forward is the strategy stuff. So it's a bit different to the operational performance and the emergency winter plan. So Josh, if you're happy, pause there and take any questions on what we've had to say to date.
Yeah, that's a good idea. Kerry's already put his hand up, so Kerry.
Thank you very much, Chair. Simon and Joe, thank you for the presentation, really helpful. Two quick questions. The first question relates to the ongoing elective backlog and how long do you think it will take us to clear?
So that's a very good question. So, but not an easy one to give a definitive answer to. So clearly we're focusing on the longest waiters. So in terms of the 104-week waiters, we have cleared that down to below the 104 weeks. The next, so we're working in chunks really, and we're not alone. That's the NHS. So the 78-week waiters, then we're focusing on next. So at the moment we're managing those patients individually who are waiting over 78 weeks to the 104. And I think in terms of our trajectory, the ambition would be to try and get that cleared down significantly, reduction by the end of March. But I don't think we're going to clear it completely by that time. But that's what our focus is.
Thank you, and that's really helpful, because obviously there's knock-on impacts in terms of the system and how we support you dealing with the backlog. The second question relates to winter pressures and ensuring that we are aligned in terms of understanding the additional monies that are likely to come down through North West London and national government. We're not hearing anything confirmed, but obviously we'd want to work together with colleagues within the acute sector and wider NHS as soon as we're clear on the NHS fund on any winter pressures money that comes down.
Yeah, agreed. And clearly, I think those discussions are taking place from a health perspective at the ICS level at this point in time. Organisations, health organisations, being asked to pull together their sort of winter plans. We've got a number of initiatives, as Joe's already alluded to, in terms of opening additional beds and putting on additional services to try and support the emergency pathway by extending the range of services that are catered for as part of same-day emergency care, around some aspects around frailty, diabetes, heart failure, etc. So we're still awaiting the outcome of those. I'm hopeful that in the next 2 to 4 weeks we should get a positive outcome. And as you know, Kerry, there have been discussions around the discharge to assess funding as well, around supporting discharges. And again, I know there are senior level conversations taking place between health and the local authorities in terms of the next steps around that funding.
Thank you, Simon.
Chris?
Thanks, Josh. I just wanted to acknowledge, I guess, on behalf of West London Trust, the interfaces that we have with London North West, supporting the recovery of and the flow through the non-elective pathways through the community services. And just to acknowledge that we're starting some work across North West London, which will benefit Ealing patients collaboratively in the virtual ward space, to see whether patients can be discharged early where safe to do so, which I think will be a good opportunity for integration between the acute trust and community services in our rapid response teams. And we continue to try and work to support flow through into Clayponds Hospital where we can, and working together with London North West and Ealing Council and the Discharge Hub. Just also to pick up on the mental health challenges, I also wanted to acknowledge the mental health challenges, and to be aware that West London Trust tends to be in a reasonably positive position in terms of mental health flow through the A&E departments, and we certainly benchmark well across London, but that doesn't mean to say we haven't got more to do. So we're monitoring the activity of our liaison psychiatry services in Ealing Hospital, and we've also been putting in a number of alternative pathways to try and divert patients who don't need to be in the emergency department but are in a mental health crisis to suitable alternative safe spaces. So we, for the last few months, have been working very closely with Mind in Ealing, and Mind is now in-reaching during the twilight period into Ealing Hospital to identify people who might benefit from their support. And we also have the Mind Safe Space now based at the Lido Centre in Mattock Lane, which is an alternative crisis option for individuals who don't need to be visiting the hospital for physical health care at the same time. But I wanted to name the fact that there are a number of joint mental health initiatives between West London Trust and CNWL, hoping to support acute flow as we go through the next few weeks.
Thanks, Chris. I would sort of agree with that. I think the other challenge, because of some of the diverts of work we're seeing, is it's not just West London in Ealing A&E, to acknowledge that. And we've got, like you're saying, we've got further work happening around virtual wards as well, as a big programme across North West London. So alongside mental health, but in cardiac and respiratory and other aspects. And we're also locally trying to do some more work around frailty as well. So some of the schemes that we're bringing on.
Yeah, and I think it's fair to say that we've got an effective working relationship, I think, Chris, in terms of between London North West and West London Health, both on a mental health perspective, but also on the discharge pathway. Your team play an active part of that, and that works well, as it does with social services and Kerry's team. So I think people work well collaboratively together, but the challenges are significant.
Agreed. Great. Any other questions then on recovery or the winter planning? I think all parts of the system are under huge amounts of pressure already.
Yeah.
Unfortunately for you both, I think yours is the one facing the most pressure most quickly. So good to know that the planning is going on and kind of risks are acknowledged. But again, as always, anything, what asks, I suppose, are there from your part of the system to the rest of us to help mitigate some of those risks? Obviously, we're facing our own pressures, and I think we've alluded to the discharge to assess funding. What else can we all do to support kind of that front line that you represent?
So I suppose the biggest message is making sure that people only come to the UTC or A&E when they absolutely need to, and to make sure, it comes back to my comment earlier about it's really important about the communication, the messages around the changes in terms of access to, in terms of primary care, that people know how to access primary care and can access primary care. I think so that's one element. The other element, I suppose, is those people who aren't registered with the GPs. Is there more we can do in terms of those patients? So part of COVID, we recognised that we identified significant cohorts of people living in our boroughs who aren't registered with GPs. So the default for them is that they do come to the UTC or A&E. And is there more that we can do for that unregistered population? And what's the process for trying to tackle that? Would be a challenge, I think. But other than that, I think is carry on doing the sort of things that we're doing, keep talking, keep sharing, keep working together, really. And I think, it is important, the working relationships, and as challenging as COVID was, it did sort of bring us all together and recognize that we're all in this together. So it has cemented some of those relationships, and it does make it a lot easier that we can pick up the phone to each other and share those problems, and people do take that on board. So let's not lose that, despite the fact that we're coming out of COVID, and let's not retrench to old ways of working, perhaps, in terms of leave it at that.
Great, thanks. Well, in terms of moving forward, I think we can move on to the way forward.
Yes, indeed. So we're in the process of developing and refreshing our trust strategy. And go to the next slide, please, Joe. And this is in recognition that our previous strategy was developed in sort of 2017-18, when shaping a healthy future was still alive. Hadn't quite been killed off at that point. So clearly that's changed. COVID has changed the landscape around us. It's 5 years on. We've got a new chief executive. We are working differently across the system. We are now part of an acute collaborative with the 4 acute trusts working together with a single chair. So it seemed entirely appropriate and timely that we developed a revised strategy for the organisation. And I think one of the things, again, COVID taught us was the importance of listening to patients and getting a view from patients. And certainly from various CQC visits, the importance of engaging with our staff as well is vitally important. So we embarked upon a process. We signed it off at the board level in sort of February time, but it started in earnest in April, developing our case for change, understanding our challenges, understanding what opportunities are and what we think the direction of travel is going forward. And then so it's in 3 parts, the April to July phase. Now we're in the July to September in terms of choices for the future as a result of the engagement process, looking at the challenges and the issues, what are people's views of how we can address that and take it forward. And then from September to October, it's sort of bringing it back, having sort of done that storming and forming and brainstorming in terms of what good looks like going forward. We will come up with a sort of final view of our strategy going forward. Next slide, please, Joe. And so we've done a lot in terms of engagement. 750 people taken part in terms of the survey in multiple languages, including Somali as a result of feedback. 2,000 of our employees have contributed out of 8,500 workforce, so over 20%. We've had we're having 3 major stakeholder events. The Brent and the Ealing ones have the Harrow and Ealing ones. Harrow took place in July, Ealing's during September, and many thanks to the council for supporting use of the hall and for people attending that. It was unfortunate, it was on the same day as a train strike, so that did affect the numbers actually attending in person, but we were running it virtually, so people did join virtually as well. And we've engaged or interviewed 30+ partner organisations, and councils have always done their strategy and engagement much better than health, I think, in the future. So hopefully this year we've gone some way to catching up by much better and a more wide-ranging engagements with different groups. So the emerging findings then, if you go to the next slide, please, Joe. So 4 main themes from the case for change is a recognition that we must work with partners to reduce health inequalities faced by the diverse communities we serve. We know Ealing, Brent and Harrow are some of the most diverse communities in London and certainly nationally. So we need to think about the services we offer, how we offer those in terms of providing equal access to patients, whether that's equal access onto our waiting list, whether that's equal access in terms of how we treat them and prioritize them for treatment, and how we make sure that they have a good understanding of what's available to them. Staff is mission critical for us in terms of we're only as good as the staff that we've got working for us. We're a product of the quality of our workforce and the volume of staff we've got in our workforce, and we're very keen as part of our sort of core 20+ initiatives to work much closer with our local communities, with our councils, etc., to make sure that we're much better at recruiting a local workforce where we can into our services, as well as attracting high caliber clinicians across the board from training programs, and making sure we've got better and stronger links with the training programs that support us, whether that's for nurses, for doctors, or other professional bodies. And we, excuse me, just push the top. And we must do better in terms of, and you've heard some of that, I've alluded to at the moment, again, recognizing some of the challenges in increasing the volume of activity we had to take of the elective stuff. We've had to look closely at our efficiency, the way we do things, our IT systems, our planning systems, and where things go wrong, why they go wrong, and what we can do about it. So that's a key part of it, is improving our internal processes to make sure that we can deliver as much activity as safely and as effectively as we can. And you know, the bottom line is we must improve that access to ensure that we're delivering the highest quality of services in a timely fashion to the patients we serve. So those are the 4 themes that come out of it, and then on top of that, there's a number of ideas in terms of how we improve on those things. So focusing on shared pathways outside of the hospital. We're doing much more in terms of engaging with primary care and GPs. The medical director has a monthly forum with primary care to talk about particular challenges and issues and how we help each other. We're looking much more at both our own data around the population health and health inequalities, but also it's helpful to be part of these type of conversations when we look at what Ealing are doing, but we're also looking at what Harrow and Brent have done, because all three of you have done similar sort of work around and your own strategies and population health and analysis. As part of the Acute Collaborative, we're looking at support services. How can we organise those more effectively? So we're in the process of implementing a new digital care system, the Cerner system. That's the same. We're doing that jointly with Hillingdon. Both Imperial and Chell West also use Cerner. So when that's fully implemented, we're due to take it and go live in August 23 and Hillingdon in October, November 23. That would put all 4 acute trusts on the same digital platform. That will massively, internally, it'll improve our efficiency and not relying on paper, but also it'll make it much more seamless for patients where they are referred from one trust to another, etc. I've already mentioned the relationships with education. And building those and making it stronger to ensure we've got a strong pipeline of recruits into the organisation. Digital, I've already sort of mentioned as part of the support services. Waiting times, I think I've talked about earlier. Research, so we serve a massive population, diverse communities, and again, I think as part of COVID, we were quite instrumental in providing access to patients to a number of clinical trials. We're determined to continue to develop that function and support that function, grow within the organisation, and provide opportunities for our patients to have more readily access to the latest drugs, the latest sort of treatment modalities, and supporting patients to access those going forward. As an organisation, we have a range of specialist services like St Mark's being the National Bowel Hospital, and ensuring we protect and develop those appropriately in conjunction with the Acute Collaborative, working jointly with other trusts in North West London. Clearly, a focus on clinical quality. One of the biggest indicators is your standard hospital mortality rate. Again, we perform extremely well on that as a trust and as an organisation, but that's only one indicator in terms of the outcomes, but it's an important indicator. But it's also about the experience of patients. And I think we've got more to do around the experience of patients. I think our clinical outcomes are very good, but sometimes we heard from Health Watch waiting too long, the efficiency side of things. So we've got more to do on that front. And again, we've already talked about emergency pathways, so I won't say any more about that in terms of our focus on those. Just to recognise the Ealing Town Hall event was the 18th of August. There was a broad agreement on ideas, most of which I think I've talked about. So the slides were circulated previously. I won't go through those again, but next slide then, please, Joe. There was something that we learned from the Town Hall event, which was excellent, was again a focusing on, when we talked about the shared pathways, some of our attendees reminded us there were still things that we could do internally to improve the way we did things for patients. All very well focusing on digitally, but how digitally able is the population? So we need to think about the less able digital population, and the fact that we need to emphasize equity more rather than just equality. It's equity of access, and therefore we've got to be proactive to try and find how we do provide that equity of access. More to do around our systems and processes being linked up. Third sector needs a stronger voice and stronger involvement with the trust. Again, one of the benefits of being more actively involved as part of COVID with each of the 3 borough integrated care boards is the recognition that the third sector does play a part in part of those conversations, and it's providing us different contacts and different voices to link our services up with. and there was a phrase around, yes, I used the phrase earlier about one of the busiest AAs in London, but I think what the plea was, you should be celebrating that as an opportunity, as a centre of excellence, and therefore you need to do it extraordinarily well. And we recognise that. We do want to do that extraordinarily well, and we think we've made massive strides in terms of how we provide those emergency services, but we want to be a beacon that others come and learn from us in terms of how we do that going forward. Staff support are really important, and it's not just about money, but what can we do to support staff from non-monetary benefits. I talked earlier about the importance of giving staff a break during the summer. We realised we had challenges around catching up with the backlog, but it was also important to give staff a proper break over the summer. And rather than just focus on quality, the outcomes will improve if we get our pathways right. So so it's thinking about how we deliver the service via pathways. It was important, rather than just thinking about quality, and also think about how you do change, and do it with staff and not without staff. Don't do it unto, do it with. So those were some of the key messages that will feed into the process. So we're considering the input that we received from the Ealing event. The next one actually is in Brent tomorrow, so there'll be more feedback. And then we've got some internal senior trust leadership workshops in terms of synthesizing that in September, as well as some sort of final one-to-one engagement events. And the intention is to have a final draft of the strategy that will go to the trust's finance and operations meeting during November, and then in recognition of some of the changes around the trust in terms of working as part of the acute collaborative, it will go for final sign-off now, not in late autumn, but it will go to the acute collaborative board in January 2023. Happy to take any questions. Whistle stop talk, but hopefully a lot of that resonates with people in terms of what they'd like to see us doing. But if there's anything we've missed or I haven't said, very happy to hear.
Thanks, Simon. I can't see any hands up. No, so I hope the Brent event tomorrow goes well, and I'm sure there'll be further updates from you over the coming months as we firm up that strategy and adopt it.
Thank you very much.
Thank you, Simon and Joe, for the updates, which takes us on to Chris. So Chris, I mean, we had quite a big discussion about the beds last time. So I don't think we need to spend too long on this, but thank you very much for providing the equalities impact assessment, which you had promised. And I don't know if you wanted just to give a brief update on the current phase of engagement.
Yes, that's perfect. Thank you, Chair. I appreciate that the Health and Wellbeing Board considered at the last meeting the background to this programme, but for those that weren't present, obviously it's listed in the minutes at page 20 of the pack, but this relates to 31 adult inpatient mental health beds on the St Bernard's Hospital site adjacent to Ealing Hospital for adults with acute mental health needs that were suspended during the COVID pandemic. And we re-provided in better quality accommodation in Hounslow 18 of those 31 beds, meaning that our net reduction in our overall bed base is 13 beds. We've reinvested all of the money into other acute mental health pathways, including a different type of bed known as a step-down bed for residents in Ealing. As a clinician, I'm aware that we've used our beds across the Ealing, Hammersmith and Fulham and Hounslow geographies as a pool of beds for many years. So the rationale really for this is very much driven by the quality of the care that we were able to provide in the old Victorian buildings at St Bernard's Hospital. And we've gone through three stages of what is likely to be a 4 or 5 stage process in order to determine the long-term future of the beds that are currently suspended. We've been through a discovery phase and some early engagement. And then we've developed some solutions and a preferred option, and it's now our intention to move towards what we're describing as an enhanced engagement stage. So this is to, over a 3-month period, subject to the agreement of the Health Scrutiny Committee in Ealing and the Trust Board later this month, as well as the Joint Health Scrutiny Committee for North West London, to follow the enhanced engagement approach, which is very similar to a consultation, which would take us to an ability to gain further information from key stakeholders and local residents to feed into a decision-making paper early in the new year. I guess the reason for coming today, and I won't prolong the discussion because I'm keeping people from their tea, was to bring the equality health impact assessments, which were specifically requested in the discussion last time. In those, we've engaged during that early engagement phase, engaged with around 130 people, 20 organisations, and for the staff EHIA, we also engaged with I think around 30 employees who were redeployed when the wards were suspended, and looked through the rather rigid domains that we are required to pay attention to in terms of our equality duties. And I think the key messages that we've heard through the EHIAs are that we've had some feedback around the impact for Ealing residents on travel to other boroughs, a potential average increase in travel of between 1/2 and 1 mile, and the impact that might have on travel time. In fact, in a number of the protected characteristics, we feel that the new proposals will actually be superior to the previous position. And we will continue to engage with individuals to ensure that we are addressing any impacts that have been identified during that enhanced engagement phase. So really, it was just to inform you of those next steps, and happy to answer any questions.
Thanks, Chris. Helpful update on where you have got to. Are there any particular questions then for Chris on that update? No, so I think we'll just note that for now, Chris, and then as you say, you're at health scrutiny later in the month, and so we'll keep an eye on proposals as they come forward. So thank you very much. And then finally, in terms of substantive items, I think Anna, we have an item on work programme.
Yeah, hi Chair, can you hear me okay?
Yes.
Yeah, I'm just going to keep video off if that's okay. It's not happy. So in some suggested items for board to consider for the November meeting. So as well as our kind of standard items from partners, there were 4 that we thought would be good for next time. So a more substantial update on the health and wellbeing board strategy, reflections and feedback from the engagement that we've done and the thematic analysis we've already done, and really trying to focus and going forward on the kind of suggested content for the strategy, which we can then obviously, along with a lot of other colleagues, write up over the remainder of the autumn. There's an item being requested on the Better Care Fund plan for this financial year. Potentially an item on the COVID lessons learnt review. That was something mentioned at this board a couple of times ago. We've now recruited into the role that's supporting us with carrying that out. So I think November will be a good time to come back and share where we're up to with that. And then potentially more of a discussion item, I suppose, on the cost of living crisis. There are some working groups being set up over the next couple of weeks in terms of really pulling together where all of the different partners are taking actions in terms of this issue, and where there are potential gaps, and really an important one for us to work together on. So I'm not quite sure what that item will look like for now, but obviously up to the board to steer that and say what would be helpful. But I think that would be a really timely discussion to have here. Thanks, Chair.
Great, thank you. We do have a year plan. I don't think it made it into the papers, but if we bring that next time, members of the board will be able to see the kind of the longer term plan. I think culminating in this cycle with the Health of the Borough report that will be published for the first time at the end of this year, year rather than calendar year, before anyone gets too excited.
Yeah, and Chair,
sorry.
Sorry, Chair, just to add on that, yes, we can do that for next time. I think also important, there is some guidance coming out in the autumn around the links between integrated care systems and health and wellbeing boards and place-based partnerships. And so there are some specific recommendations in there about what we need to bring. So, for example, the ICS strategy, beefing up potentially the role of health and wellbeing board a bit more in terms of receiving JSNAs, things like that. So, and we can weave that into the forward plan and bring it next time. Thank you.
Great, thanks, Anna. Simon.
Yeah, my question or comment was specifically around the cost of living crisis, and I suppose what would be really helpful, Anna, is if there are a range of initiatives the council or Chris, other organisations are doing, is if we could find a way of sharing that early on in terms of some of the thinking and the initiatives, so that, and I'm happy to share what we're doing, but I think it would be really helpful if we could join up the thinking around those kind of things, both for our staff and more broadly for the population and patients we serve.
I think that's a really helpful suggestion. I think Anna's probably raised her hand to say yes, I imagine.
I have. I think it was just a bit of a reassurance that we're not waiting until November to do this work. There's a lot happening. I'm about to go on leave, but if I leave that maybe with Kerry to link up with colleagues on the board in terms of sharing that. I think there's a lot happening probably quite quickly over the next couple of weeks on this. So yeah, definitely helpful. Thank you.
Thanks. And Neha, just before I bring you in, Maggie, there was a question from you on something related. I don't know if you wanted to pick that up now, because we are running short on time. So if you want to just flag that question, and I know Kerry's got a brief response. You're muted, Maggie. Sorry.
Sorry, I clicked it, but it didn't move fast enough. Sorry about that. So really just be wondering, is there going to be an opportunity for people to contribute to that submission? We understand that the Ealing and other boroughs are planning to make a submission to the inquiry, the national inquiry. And we're just wondering if there was any.
Maggie, I was just thinking about the energy price question, because we were just discussing.
Oh, sorry. Yeah,
sorry. I'm skipping around a little, but
both of them came up actually. Sorry, in that last little exchange. So, right, on the energy price thing, basically we were just wondering, will the discretionary elements of the charging system be used to classify certain energy costs as a disability related expenditure? Obviously, for a lot of people with disabilities, this, energy costs are going to be really, really problematic. So to what extent that might be taken up by the council as publicising more about the disability related expenditures, and to what extent that could help cover energy costs. So that was my question there. Thank you.
Kerry.
Thank you, Chair. Thank you for the question, Maggie. Absolutely. So this is something we'll be promoting through the cost of living crisis planning group, in terms of making people aware of the disability related expenditure opportunities that are available to them. And this will be part of a wider programme of providing advice and support to people who are going to be experiencing the very real pressures as a result of inflation.
Okay, and then, sorry, Maggie, I missed the link between the other one, so I don't know, pick up that one as well, and then in terms of the submissions to the national inquiry, while we're on that, and
okay,
so we will I'll come back to you very shortly.
Okay, so do you want me to take it now?
Yeah, go ahead.
Yeah, the national inquiry. Yeah, so sorry. So basically it's just that obviously there is a national inquiry. SCAG put in submissions earlier on about a lot of learning in Ealing, as has been apparent even in this last exchange. Thank you so much. So really just to know, will the public or the voluntary and community sector be able to feed into that in some way, or will the submissions at least be available to the public after you've made them? Thank you.
Kerry, I don't know if you or Anna were picking that one up.
I'm happy to pick it up if Anna's okay with that, Chair. Thank you. Thank you for the question again, Maggie. So we're still trying to understand exactly what the specific routes will be to for local authorities to respond to the national inquiry. We will keep you briefed as we progress. My assumption is that submissions will be publicly available, but that's something we're waiting to confirm, and completely agree with you. There's been some really strong learning in Ealing. We had one of the first designated care settings in the country. We had really strong partnership working around support to care homes in Ealing. I think there's some really positive learning on a local level, as well as less positive learning on a national level through the inquiry process.
Thanks, Kerry. Neha, sorry, on the work programme.
No problem. It was just at the next meeting or a meeting after, I think we should bring the new programme of medical examiners review of non-coroner cases, deaths in the future, which is going to be a statutory requirement from April next year.
Great, thank you. I'm sure Anna can pop that on the agenda of the work programme. We are hitting 8 o'clock, and I know colleagues have been working long days already, and Neha's on call as well. Luckily not had to drop off yet. I know I won't say that, just in case. I won't tempt fate for you, Neha. We've managed to cover a couple of questions from the public. I am aware it's 8 o'clock. Anything that hasn't been covered, we do have responses for, and we can get those out via email, I think, or on the website. But apologies, we've not been able to get to them all. What I will say in future, some of them are not necessarily for this board. Some of them are more to, I know, James, you had one around London Ambulance Service, probably better for health and adult social services scrutiny panel rather than us. We don't have a LAS representative on the board. So although clearly it has an impact on Simon's and Joe's work, little that we can offer by way of response in terms of some of the specifics. But in terms of what responses we can do, we will circulate them to those who asked them, and I think put them with the papers as well.
Could I very quickly just say, it's not about the handover times at hospitals, it's about the response times for the different categories of call to the residents. And Ealing has, the response times vary by borough, by borough, by borough. And at present, they're not being published. They used to be available, and the ambulance service is not releasing them. And obviously, performance information does transparency and drives improvement. The other question, very quickly, and again, appreciate you circulating it, is about the National NHS GP Patient Survey, which is a very robust annual survey which contains a wide range of measures. It's statistically based. It's far more informative than just having a volunteer sitting in a GP surgery for half an hour talking to whoever comes by. It is really informative and invaluable. And it's also free to us. So there are great spreadsheets, there's great analysis. If you could possibly share the 4 sample charts I shared, I submitted to the officer with colleagues, but I think there's real information and value there. And I mean, I did some 4 charts just showing for the Ealing GP surgeries, the wide range in patient perceptions, like how easy is it to get through on the phone between, it basically runs from terrible to fantastic and so on. And I think there's a real wealth, which could, so if some work could be done on that survey, I'd happy to engage with any officer who's nominated. And I think there could be real information for the Wellbeing Board, because it's obviously looking at, just as you take these quarterly reports from Health Watch, this, as Councillor Razza has observed in the past, those are just who comes by. This is a proper statistical weighted sample, and you can get year-on-year comparisons and surgery-to-surgery comparisons. It's just such a goldmine, and I was just asking if it could be thought about as a work programme item.
It is going to the health scrutiny panel later this month, so it is being looked at, and then whatever scrutiny and accountability needs to be done will happen at that body. So it is on the work programme of another body, which is, I think, the point I was trying to tangentially make. On the ambulance service times, they're not here, so we can't ask them to publish as for us. But I think it is just gone 8 o'clock, so I think we will draw to a close there. Thank you very much to everyone for attending, presenting, and your comments and questions. Thank you very much. I will see you all on the 16th of November at our next